Oh my god. It's disgusting. It's massive.
So this is why he couldn't get rid of it with exercise and diet. You can see it's not fat. This is glandular breast tissue, very dense. Unfortunately, there's nothing you can do besides surgery.
What's up guys, Derek, moreplacemordates.com. Today we're going to be reacting to more gyno information and education. So if you recall, we ended up reacting to a video on Dr. Daniel Aronov's TikTok before about gyno removal. So he has quite a few of these. He actually told me himself, he actually reached out after the last video, which was cool. He said he does around 2 gyno surgeries a day. Like, holy fuck, that's a lot of gyno. By far, the vast majority have never used steroids before in their life. And he kind of was talking about, you know, he does a lot of bodybuilders, agrees with with proper cycling, the risk of developing man boobs is much lower. He does get the odd patient though, who says they did everything perfectly and still ended up with it, which obviously comes down to genetic, you know, propensity, individual variability. The only reason we're back on his page is because he posted a video recently about another gyno surgery, but one of the statements made at the end of the video I thought was kind of interesting and worth rebutting because it is, in my opinion, a little bit misleading. Now, again, I'm a fan of this guy. Just as a preface to this whole thing, he obviously has very worked out his niche on the platform and figured out a way to scale his business model, which is cool to see. So anyways, this is the video in question. I'm gonna have to mute the first part because it's fucking loud. My fucking god. So hang on, I'm going to pause it. Okay, so my patient works out and has an amazing body. So he's pointing out the titties here. He just hates his puffy nipples. Here he is taking out the glandular tissue. And that one's a heater, dude. Holy fuck. So a lot people don't realize how much bigger the actual glandular mass is underneath everything than, you know, it appears on the outside. He takes it out, the guy's looking the guy's face, he's looking at it, he's like, what the fuck? That was inside me?
Oh my god. It's disgusting. It's massive.
So this is why he couldn't
He's like hanging it over his face, like, fucking look at it, look at it.
get rid of it with exercise and diet. You can see it's not fat. This is glandular breast tissue.
Yeah, so you're not gonna get rid of it with diet, exercise, you know, a calorie deficit. This is actual tissue buildup that is a result of stimulatory inputs like estrogen, GH/IGF-1 downstream, prolactin, progestogenic activity at the progesterone receptor, etc. And once this is developed to a certain extent, you know, surgery is likely an inevitable thing if you want to actually have a cosmetically appealing chest area again. Now, again, though, with this guy, well, actually, let's just say in general, does every single person need gyno surgery who gets gyno? Because, of course, once you've developed this tissue, like, look how big this fucking thing is. It looks like a goddamn seafood appetizer. Like, do you think that you're going to be able to, you know, get rid of it with some sort of intervention? Probably not, you would think, right? And that's what he goes on to talk about here.
Very dense. Unfortunately, there's nothing you can do besides surgery.
It says, unfortunately, there's nothing you can do besides surgery. So, of course, expectedly, I get tagged in it because I've done a lot of videos recently on selective estrogen receptor modulation in terms of how it can be implemented to inhibit persistent gyno and or ideally like brand new gyno. Like, you don't want it to be something from, you know, a decade ago in puberty ideally, but even if that is the case where you have pubertal gyno pre-existing, does it still work? From what we've seen clinically and anecdotally, yes, it seems to work to a degree. So let's just get into this because the way he's making it sound is once you have this tissue, if it's, you know, cosmetically displeasing whatsoever, you need to go into the office and get a fucking surgery done. Now, is that necessarily the case? No. So I've talked a lot about, you know, tamoxifen, raloxophene, different SERMs, their action at breast tissue, antagonism of estrogen receptors and whatnot, and how this could be implemented. And clinically, we see, you know, quite a bit of a fair bit of literature, enough to reinforce the efficacy of these products in this context on raloxophene and tamoxifen deployed in individuals with gynecomastia. So here is a more recent study, one of the more, the recent videos I did, I was referencing a pretty old one just as a head-to-head comparison of Raloxophene and Novadex. But here we can look at the actual update on management of adolescent gynecomastia. Now, obviously, we're talking about puberty-induced gyno. Is it directly relevant to steroid users too? Yeah, it is, because at the end of the day, it's the same stimulatory inputs that are going to be contributing to the gyno development. So, obviously, besides intelligent cycle design and whatnot, getting down to the root of it, if you cannot avoid the gyno, and if you're pre-existing, like predisposed to it genetically, and you just get it naturally, like obviously, this is a very applicable update to go over. Skipping to the pharmacological treatment section. So here we can see a summary of different kinds of interventions and their effects in sample sizes and whatnot. So here they talk about tamoxifen, a systematic review to assess the efficacy of tamoxifen in the management of idiopathic pubertal gynecomastia was performed. 59 studies were selected. There were no randomized controlled studies. The studies found have methodological flaws, but show promising results. So again, obviously not perfectly designed, but frankly, like, I don't think it's very hard to figure out if you have a reduction in a fucking titty. Like maybe underneath the surface, you can't see how big the glandular mass is, shifting or fucking maneuvering or shrinking, but visually in the mirror, if you are a patient who is otherwise displeased with what you see, and then it improves, like, I guess it's a little bit subjective as well, but I mean, I can't imagine this many people, like, you can't just disregard the fuck out of these studies when there's this much promising data, and in addition to that, the anecdotal reports we see in the bodybuilding community really reinforce the findings. So to me, like, I get methodological flaws. Some people off the bat might be like, oh, we'll fucking disregard it. I don't think it should be, because at least anecdotally, we see the results reinforced quite strongly. So no clinical side effects were reported or observed. They concluded that tamoxifen may be effective for the treatment of pubertal gynecomastia. It seems safe to use, and randomized controlled studies are necessary to confirm this indication. Retrospective chart review of men presenting to a breast clinic for gynecomastia found that only 13 of 220 patients required medication for treatment. Patients were treated with 10 milligrams of tamoxifen per day. So keep in mind, 10 milligrams, bro. Remember Mark Plumer? He was doing fucking 80 milligrams. Definitely not necessary, dude. Now again, is 10 milligrams, high enough? That may not be, but 80 milligrams, like, you definitely don't need that, and that is why he ended up with brutal side effects. And again, tamoxifen is not even the superior option. You will see shortly when we get to Raloxophene. So for 3 months, and 10 of the 13 had resolution of pain and breast enlargement. Randomized controlled trial of 80 patients also found that 20 milligrams of tamoxifen once per week is as effective as 20 milligrams once per day. Durman et al. Evaluated the efficacy of tamoxifen treatment in 37 patients with pubertal gynecomastia with with a diameter of over 3 centimeters. Pain and size reduction was seen in all patients with tamoxifen treatment. No long-term side effects of tamoxifen were observed. The dose of tamoxifen was increased in 3 patients due to poor response. 2 of the treatment group had recurrence problem at follow-up. No patient required breast surgery. Devoto et al. Studied 43 patients with gyno, aged 12 to 62. 27 patients had a pubertal physiological gynecomastia. 20 patients had mastodynia, and in 33, gynecomastia had a diameter over 4 centimeters. All were treated with tamoxifen 20 milligrams per day for 6 months. Mastodynia disappeared in all patients at 3 months. At 6 months, gynecomastia disappeared in 26 patients, 62% of them, but relapsed in 27%. 52% of gynecomastias over 4 centimeters and 90% of those less than 4 centimeters in diameter disappeared. 56% of gynecomastias lasting for more than 2 years and 70% of those of a shorter duration disappeared. They concluded that tamoxifen is safe and effective for the treatment of gynecomastia, and larger lesions have a lower response to treatment. Another 2 small double-blind crossover trials found only modest benefit when compared with placebo. Histologically, the therapeutic effect of tamoxifen appears to be satisfactory. In 3 cases who reported dissatisfaction with the results of tamoxifen treatment were therefore submitted to adenectomy preceded by liposuction. Pathology results showed adipose tissue alone with no evidence of intraductal epithelial proliferation. The lack of residual glandular breast tissue after treatment with tamoxifen proves that it is effective in histopathologically eliminating pubertal gynecomastia. Long-term safety of tamoxifen was evaluated in 10 pubertal boys treated with tamoxifen for gynecomastia for more than 3 months. They were evaluated after 2.5 to 7 years. to determine the side effects of this therapy. Authors did not find any serious side effects of tamoxifen in these patients. Now, moving on to raloxophene, the big boy. It is a second-generation SERM in 34 healthy males at a dose of 60 milligrams per day for 1 month. It increased serum tests by 20%, slightly decreased serum estradiol when used in eugonadal with patients with gynecomastia. 75% had and by the way, eugonadal meaning that they're not hypogonadal, as in they have normal testosterone production. 75% had a reduction in the size of breast tissue of at least 50%, average 73% in the first 2 months of treatment. However, the study was small and the males have a wide range of ages. In 38 patients with persistent pubertal gynecomastia who received reassurance alone or a 3 to 9 month course of an estrogen receptor modifier, tamoxifen or raloxophene, there was a mean reduction in breast nodule diameter by 2.1 centimeters after treatment with tamoxifen and 2.5 centimeters with raloxophene. Some improvement was seen in 86% of patients receiving tamoxifen and in 91% receiving raloxophene, but a greater proportion had a significant decrease with raloxophene, 86%, than tamoxifen, 41%. No side effects were seen in any patients. Authors suggested that raloxophene may be safe and effective in reducing persistent pubertal gynecomastia with a better response compared to tamoxifen. And that's the study we often reference. Anyways, then it goes on to talk about aromatase inhibitors. It talks about danazol, which is not something I would, not options I would be considering, to be honest. I think selective estrogen receptor modulation is definitely the most promising intervention. And it is definitely something to run by your doctor before you go under the knife. If you have, now again, this depends on the severity of your gyno. Like I have actually seen firsthand many individuals with gyno that is, mentally debilitating. Like they're actually, embarrassed to go out in public with it and take off their shirt, totally reverse their gyno with raloxophene. Now, as well as tamoxifen, to be honest, but raloxophene is just superior in its, like the parent drug is actually what's active, whereas with tamoxifen, it's a prodrug. And if you have certain genetic polymorphisms, you may end up being a non-responder despite, thinking that you used more than an efficacious dose. It is a prodrug at the end of the day, and your metabolism, your individually genetically determined metabolism patterns may otherwise render it a useless drug for you. And that's why raloxophene, not only better side effect profile, but just more effective overall for the vast majority of people. So anyways, is this something that if you have it, you have to get it cut out? No, not necessarily. This is something that has been clinically proven, or at least with reasonable data that is reinforced by a fuck ton of anecdotal findings in the bodybuilding community, that SERM therapy is decent for those with newly onset gyno and or like relatively not intense gyno. So if you don't have like a giant fucking baseball titty, like it's worth potentially looking at. Now again, there's different severities of gyno. Like for example, here they have different grades of gynecomastia, and here they have on the left, like for example, it goes from grade 1 all the way to grade 3. And if you have something like this, like are you going to be able to get away with it, shrink this to nothing with raloxophene? I highly doubt it. This is something that I would speculate needs surgery. This, maybe surgery. Something like this is the majority of people with gyno. They're dealing with something more like this, and I would imagine that is pretty manageable with SERM therapy for the majority of people. Now again, that's just me speculating. That's not an official medical opinion whatsoever, but I would like to see more knowledge be spread around SERM therapy before surgery potentially. Obviously, by physicians and doctors and whatnot, not by, you know what I mean? And, but in addition to that, more novel delivery mechanisms, like the bioavailability of raloxophene is not that good. It's pretty like overall, it's like almost fully destroyed during the metabolism process. And what gets through is what, elicits its pharmacological effects on the breast tissue. But hypothetically, you might be able to get away with less liver stress and more direct activity at the localized tissue level if you use a topical raloxophene. That's something I'm looking into with a compounding pharmacy right now to see if that is a possibility for working with my HRT clinic in the future. But for now, obviously oral raloxophene is what is studied clinically, and tamoxifen also works pretty well as well. Just not as well as raloxophene in my experience and in my opinion. So Anyways, if you have persistent gynecomastia from puberty and or, you just got it self-induced through some medium, this might be worth looking at. For some individuals where it's very, very developed, you're probably going to need surgery. But for other individuals where you have some minor development, some grade 1 gynecomastia, maybe even grade 2A, I'm not sure exactly what that quantifies, but grade 1, I would imagine something like Raloxophene would be pretty fucking effective for a lot of people that may otherwise be considering going under the knife. So definitely something to talk about with your doctor. Thank you guys for watching. Like, subscribe, check out my blog, moreplacemordates.com. Follow me on Instagram at moreplacemordates. Facebook, Snapchat, BitChute, Twitter, TikTok, Apple Podcasts. If you want to support the channel, you can check out anything I'm associated with in the video description below. My TRT clinic. It's all telemedicine from the comfort of your own home. I recommended lab tests and diagnostics to stay on top of your health and get high quality medical oversight so you don't end up getting gynecomastia during something as simple as therapeutic testosterone replacement therapy, because some clinics will fuck you up and or put you on anastrozole proactively in order to prevent you from getting gyno, even though it might fuck up your heart, that kind of shit, and your brain. So you want somebody who is highly qualified to oversee your hormone replacement therapy practices, as well as any other endeavors you may be, doing. So stay on top of that, and anything else I am associated with, it is all in the video description below if you want to check it out. So thank you guys for watching. Talk to you soon.